This module, I am going to discuss with you the aerosol therapy in bronchial asthma. The aerosol therapy has become the mainstay of the treatment of bronchial asthma because various drugs are now available in the aerosol form, and there are a large number of advantages where if the drug is administered in the aerosol form, the dose required is small, the effect is fast, and in disease like asthma, where the drug needs to be taken on a longer basis, a long time, it is advisable to have the least side effects. And the aerosol therapy has been proved to be free of major side effects in spite of the long-term use of the drug. Therefore, we shall discuss the aerosol therapy in bronchial asthma today. When we talk of the aerosol therapy, it's very important to have a proper device which is going to deliver the drug at the site and in a proper concentration. And to achieve this, I think there are various devices. As you can see in this slide, there are a large number of devices. There are inhalers, dry powder and the pressurized inhalers, nebulizers and spacers. I shall explain to you in detail what everything means. So the current delivery platforms are of three types. The pressured meter dose inhaler, which is very popular, which used to be a gold standard, and it could be used with the help of the spacer. So MDI with a spacer. The spacer could be static or non-static. It could be valve, without valve, or it could be with mask. It depends on the patient's need, what to use, when to use. The next is the dry powder inhaler, which is gaining more and more popularity these days throughout the world. And these dry powder inhalers could be available as a single dose delivery with a capsule put into the device and inhaled, or it could be a multi-dose dry powder inhaler where there are multi-doses stored in the reservoir. Lastly, the nebulizer, which are by and large used in acute disease condition or in children or in the elderly population who do not find it comfortable to use MDIs or dry powder inhalers. It could be jet nebulizer, ultrasonic nebulizer, or a battery operated nebulizer. So all inhalers devices are similar in efficacy. Whatever the device you use is for the convenience of administration. The delivery of the concentration or the amount of drug is almost similar with all the devices. And that's a study which was published in CHEST 2005, which clearly states that the overall estimated dose delivery is almost equal throughout. So therefore, there is no real difference between various inhaler devices, and you can use you can select the device on the basis of its cost and affordability of the patient. So use the cheapest one, MDI, which would give relief to the patient. What happens when the drug is inhaled in the body? As you can see in this particular slide, around 10 to 20% gets deposited in the lung. Quite amazing. A very small portion, up to 20%, gets deposited in the lung. Mouth and oropharynx, almost 60 to 80% gets swallowed from that route because we inhale through mouth. After 60 to 80% are swallowed, there is absorption from the gut because it reaches the GI tract, and then it meets the liver. That is the first phase of inactivation. Most of the drug is inactivated in the liver, and whatever is not inactivated is passed through the intestines outside. The 10 to 20% that is deposited in the lung, there is some of it gets absorbed from the lung and enters the systemic circulation, and that portion is responsible for systemic side effects. So, large amount of drug gets deposited in the bronchial tree, some amount passes into the circulation. Whatever passes through circulation is responsible for systemic side effects. And as you can see here, a large chunk goes in the intestines, a smaller portion gets into the lung. So, that is advantageous to prevent the side effects. So, where are the targets of these bronchodilators? We want them to act at a particular place, and the M3 receptors are more in bronchioles, bronchus and trachea all over, but they are more in the bronchioles, and therefore, the action is more at the level of the trachea. The drug concentration or effect gradually declines as the drug reaches the bronchioles, whereas beta 2 receptors are in a reverse way, and they can start their action and becomes maximum at the larger airways. As you can see the graph which is exceeding the top. So, if we compare both the drugs, it is the middle portion which gets the maximum of both the drugs, and that is the bronchus. And in treatment of bronchial asthma, what we really need is the maximum concentration in the bronchus, and that is achieved by both these inhalers because of the presence of receptors in the larger numbers. Now, this is airway smooth muscle which then opens up, and as you can see here, in the middle portion where both the drugs are acting, there is maximum airway smooth muscle action. It relaxes well, opens up the bronchi and relieves the obstruction. Now, if we look at steroids, what is the concentration post inhalation? In healthy volunteers, if he inhales a fluticasone inhaler, a peak is built up immediately, say within about 1 hour, and gradually there is a drop, and around 8 hours to 9 hours the drug drops to a lower level. So, in COPD it is a different, the peak is not achieved, the maximum concentration, plasma fluticasone concentration of about 200 nanograms is only achieved, and there is a rapid decline to come to a basal level. So, that is the difference. If you give steroids in COPD, the concentration achieved is less. So, what is the impact of inhalers on poorly controlled disease? Reduced quality of life. That means the patient will suffer from more symptoms, restriction of activities, there could be frequent exacerbation of the disease, more doctor and hospital visits and admission, and more medications leading to possible more side effects. So, these are the disadvantages. Therefore, your aim is to control the disease well, so that all these problems are avoided for a patient. So, the biggest driver of disease control is really the ability of the person to use a particular inhaler device. Inhalers are very good, very effective, very safe, but the efficacy of the inhaler is directly related to the technique of the person to use that particular device. And therefore, what is important? Select a device which your patient can use well. So, let us look at each device in a very critical way. MDI, very popular device, it is very good, it is compact, portable, it has pressurized 200 meter doses, convenient to carry, quick to use, economical, track record of more than 50 years in the market and patients are still using it, highly reproducible dosing. So, no question about its efficacy, but the problem lies in the fact that it is highly technique dependent. That means the coordination between actuation and inhalation is extremely important. Slow, deep inhalation is required to be done by the patient. So, in acute attacks, sometimes it is difficult for the patient to do that. Breath hold is important. Again, patient has to be normal to do that. Possible to get no drug in the lungs with a very bad technique. That's a point to remember. If the technique is bad, zero drug in the lungs. High velocity of drug spray and deposition in the oropharynx, and the propellants which are added sometimes may irritate the respiratory passage and lead to bronchial irritation. The surveys have shown that if you don't give specific instructions to the patient, the ability to use is very poor. If the patient is educated on how to use it and explained about the proper technique of use, the response and the result of MDIs improve. So, what are the steps? When you prescribe an inhaler to the patient, it is very important to spend few minutes explaining to him the proper steps in using MDI so that your prescription becomes effective. And these steps are: first, the patient removes the cap from the inhaler, shake the inhaler, hold it upright, tilt the head slightly back, close the lips around the inhaler, begin to breathe in and activate the inhaler. What you must remember is inhale slowly and deeply. If you do it fast, the drug will not get down. Inhale slowly and deeply and hold the breath for 10 seconds. So, use one puff, breathe out through the nose by closing the mouth, wait for 30 seconds before taking another puff. So, the treatment consists of 2 puffs at a time, but you must take one puff, wait for 30 seconds and then repeat the next puff. If proper technique is used, proper results are obtained with the nebulizer. What are the errors we have come across while using MDI? At least 20 studies with more than 3,000 patients. Incidence of misuse from a wide range, from 12 to 89%. The mean was 38%. So, a large number misuses the inhalers. What are the common errors? The error between coordination of actuation and inhalation, short breath hold, rapid inspiration, inadequate or no shaking of inhaler, abrupt discontinuation of inspiration, that is due to the cold freon effect. Young and old are unable to use it and comply with the instructions, and occasional versus regular user. An occasional user always commits mistake. A regular user may be trained in using it better. Release of the drug too early and release of the drug too late. Either patient delays in pressing the inhaler. He takes the inhalation first and then presses, or before starting the inhalation he presses. So, too early or too late also hampers the drug delivery. That is why the technique is important. You must ensure that your patient has watched it, learned it and practices it. Why do these problems occur? I think the fault is with the doctors. We are very quick in writing the prescription, but we do not have time to explain to the patient the technique. So, there is no definite format, but you must follow it and train your patient. What are the clinical consequences if the patient does not use the MDI properly? The clinical consequences are reduced amount of drug in the airways, decreased effect, lack of confidence in therapy, reduced compliance, poor control of disease, decreased quality of life and higher cost. Hospitalization would increase these economic costs and economic burden. The solution for misuse definitely now is to use the dry powder inhaler. The patients have found that easier to use, so they are shifting on to that, which was introduced in 1960s. There are no propellants, breath actuated delivery, patient's own inspiratory effort counts the actuation of the device, and at least 10 types and 30 are in development. They could be capsules, blisters, reservoirs and repressible reservoirs. What are the pros and cons of DPI? Well, it is easier to use than DPI. That is the major advantage of dry powder inhalers. It is breath actuated. So, unless the patient makes effort to inhale, the drug will not be delivered. It is single or multi-dose, compact. No propellants are required, so no counter irritation of the airways and low initial cost, and therefore they are very popular, very well accepted by the patient. Well, they are easy to use, the inspiratory flow dependent. That means even older patients can use them, severe COPDs can use them, and patients with acute attack also find it little easier than MDI to use them. Therefore, it is very popular to use these things. Not at all age groups, because sometimes a child who cannot inhale may not be able to do that. So, you have to select. I think the best practice is to demonstrate and watch whether your patient has learned the inhaler technique well. Some need loading, put one capsule every time he inhales, and that might work out to be little expensive. They are moisture sensitive. So, in a country with high humidity, the capsules, there is a fear that they may get soggy and the delivery may be hampered. So, drug delivery can be hampered because of the weather. The dose is lost if the patient exhales into the device. So, the patient might not get adequate drug. It contains lactose. Of course, now lactose free capsules are being marketed, but by and large it has a lactose in it, and therefore there could be problems. So, this is just to show you different devices. Are there any other device? A device in fact which combines the properties of dry powder inhaler and an MDI is now in the making, and that's called as Autohaler. It is a breath actuated pressurized meter dose inhaler. That is called breath actuated device, the Autohaler. Well, what are the breath actuated devices? They are like MDI. Patient's inhalation through the device triggers the mechanism that fires the pressurized MDI. Firing and inhalation are automatically coordinated. It is this type of device which patient inhalation triggers the release of drug. There is no need to coordinate actuation and inhalation. Actuated at a flow rate of 20 to 30 liters per minute, an audible soft click or a whoosh sound to confirm the dose dipping. And it has been found that the drug delivery is extremely good and gets deposited into the lungs in a very uniform fashion. Even the lung function studies have shown that the drug is very effective when taken properly, and it is much easier to use this particular device. These are the lung function changes which are seen after administration of the drug, which shows that it is equal compared to other devices. If we compare all the devices that are available, that is pressurized MDI with spacer, actuated device, breath actuated device, Autohaler, Turbohaler, AccuHaler, ClickHaler, I think most of the devices are same except pressurized MDI, which is very much patient effort dependent. And that's the note we have to take. So, use any device which your patient prefers. He is the master of selecting the device. Any device that suits him, device that he likes and able to use it well and he can afford, should be the device prescribed to him. Now, let us look at different medications that are available today and what are the goals of treatment. Now, when we give medication to a patient of asthma, we have certain aims in our mind, and they are: the drugs should be safe and effective medication delivery, provides the least amount of medication needed to allow the student to be active and symptom free, avoid adverse effects from medications, and meet students and families' expectation regarding the medication. The relationship with the primary health care provider who is knowledgeable of current asthma treatment guidelines, so proper guidance onto the treatment, development, sharing and use of personalized asthma action plan or asthma management plan, and monitoring of symptoms with a peak flow meter and pulmonary function testing. Catching early warning signs is extremely important in the treatment of asthma. Well, every 6 months asthma checkup should be done to see whether the asthma is under control or not. More frequently for asthma that is out of control, you can see after 3 months, 1 month, depending on the symptoms, or stepping up and down of therapy as needed. Different devices, you and patient have to have a partnership to select the device which suits your patient. And when we talk of medications, there are 2 types of medications: controller versus reliever. The controller medications, they are daily medications for all persistent asthma. It helps in long-term control and it should be anti-inflammatory. Reliever or quick relief medications, they are essentially bronchodilators. They are used as needed for all asthma patients and of all severity patients. They are used as and when required also to prevent exercise-induced asthma. They are essentially bronchodilators, and we can combine it with oral steroid bursts if needed. How they should be given? Either through MDI or a dry powder inhaler, nebulizer, or orally. Today I will not discuss the oral medications. I will only restrict myself to inhaled medications. It is very important to test the patient's technique during each visit when he comes for follow-up. So, there is a aerosol meter dose inhalers and chamber with spacers is a very convenient way for the patients who cannot use the meter dose inhaler alone. And I told you how it works, but that is the photograph which shows how the technique should be. It should be held little away from the mouth and coordinate with the inhalation, or person can use a spacer with it. That is the spacer and a wall spacer which can be used. And you can see here that is how it works. So, how do you plan a medication, inhaler medications in your patients with bronchial asthma? Let us look at it. Mild intermittent, only reliever as and when required. Controller, mild persistent, you should combine controller and reliever. Moderate persistent, you must give controller plus a long-acting bronchodilator and reliever, and severe persistent, controller plus long-acting bronchodilator and reliever. So, what are the controllers? Controllers are inhaled steroids. They reduce the airway swelling over time, they decrease airway hyperresponsiveness, they must be taken daily even if there are no symptoms, and will not relieve acute asthma symptoms. Because they control the disease, they are not so much useful to relieve the symptoms. The inhaled corticosteroids, when used consistently over time, will prevent or control inflammation and acute episodes. The dose strength may need to be increased or decreased depending on the season of the year, and inhaled steroids start to work in days to weeks as long as they are continued. There could be fluticasone, budesonide, mometasone, beclomethasone are the drugs, steroid drugs available in our country. Their potential adverse effects, there could be cough, dysphonia, thrush. The best way to prevent these side effects is that the patient gargles thoroughly after he inhales the drug. The therapeutic issues, you can use chambers if it is an MDI, or spacers if the patient is using MDI. Different inhaled steroids are not interchangeable, and therefore you must select one and try on your patient. There is a lot of steroid phobia exists, but you will have to educate your patient that inhaled steroids are safe and they are free of side effects, and in spite of taking in a standard dose for a longer period, they are free from severe or major side effects. That is what is the doctor's job. So, non-steroid anti-inflammatories are there, but it is not my domain today. I am sticking to the inhaled drugs. Then there is a group which is now very popular, and that is long-acting beta-2 agonist like salmeterol and formoterol, and recently introduced indacaterol. The potential adverse effects: tachycardia, tremors, hypokalemia. Therapeutic issues: should not be used in place of anti-inflammatory therapy. They should be combined with anti-inflammatory. So the combination medication is good and it works better in patients. The reliever bronchodilator's job is to relax or open up the constricted muscles. It should be taken as needed they only relieve symptoms, therefore should be taken as needed. Need to wait 1 to 2 minutes between puffs for best deposition of medication in the lungs. The overuse is a big warning sign indicating the child's asthma may not be very well controlled. They could be short acting like salbutamol, which is called albuterol in other countries, levosalbutamol, or there could be terbutaline. These are the three: salbutamol, levosalbutamol and terbutaline are the three short-acting beta-2 agonists available in our country. Potential side effects again: tremors, tachycardia, headache. And the therapeutic issues: the drugs of choice for acute bronchospasm. They give immediate relief and therefore they are used. The third group, which is very effective and important, is anticholinergics. Ipratropium bromide is the drug which is used as an anticholinergic for the relief of acute bronchospasm, especially if salbutamol alone is not effective. Potential side effects: dry mouth, flushed skin, tachycardia. Therapeutic issues: it does not reverse allergy-induced bronchospasm or block exercise-induced asthma and may be additive effect to beta agonists slower than the onset. Therefore, if you combine salbutamol and ipratropium, the effect is better, quicker and long lasting. When you follow up the patient, please remember to ask about daytime and nighttime symptoms and frequency of salbutamol use. Assess current severity and control, and if poor control, refer to the doctor for improving or adding the drugs to give him relief from his. So better control should be achieved by adjusting the treatment. Be aware of the medications that are not being used and educate the family to help the patient control his disease. Give guidance and suggestions how to better obtain medications and gadgets and at home and at school. Consider family dynamics when communicating. Check the inhaler technique at every visit so that that major aspect of failure of treatment is removed and reinforce successful behavior of the patient. So, friends, I tried to explain to you the details of bronchial asthma therapy through the aerosol. Thank you very much.